Hi, thank you so much for having me. I want to just apologize in advance. I'm actually getting over a flu, so my voice is a little creaky, and if I cough, please don't mind that. Just getting over a flu. Thankfully, was only just a flu, but I might cough just a little bit. Thank you so much to the organizers for having me here today. Despite my illness, I'm very, very happy to be here. I'm very happy that I could join you all, and I'm very much looking forward to the question and answer session later. So today I'll be talking about health data and health equity, and just going through some of the challenges and opportunities that are presented by health data and how they can address health equity. So next slide. I don't advance my slides, right? Okay. And before I get started, I just want to start with a land acknowledgement. And if we had all been together in person, I would have done a different kind of land acknowledgement. But here where I am in the United States, this has been somewhat of a sort of new tradition of acknowledging the indigenous peoples of the United States, who are often erased from everyday conversations and discussions of history. And so land acknowledgements before presentations are just a way to acknowledge the indigenous lands that we are on in the United States. So I am in New York City, which is the land of the Lenape community. And these land acknowledgements, again, kind of work against the erasure of indigenous peoples and indigenous histories, and also ask us to think about some questions. What does it mean to live in a post and neo-colonial world? How did it take for us to get here? And how do we, right? Not just acknowledging the land of these communities, but think about how we can be accountable for our part in history and our actions for today. Next slide, please. So I started off this slide by saying that I also couldn't begin a talk about health data and health equity without talking about the the global health equity disaster, but the especially pronounced health equity disaster of COVID-19 that we see in the United States, with Black and Brown communities in the United States having disproportionate COVID-19 cases, as well as disproportionate negative outcomes of COVID-19. And I want to be sure that I state, echoing Dr. Jones, past president of the American Society for Public Health, who noted that it is the reasons that we see disproportionate effects of COVID-19 in Black and Brown communities in the United States is not because of an innate biological difference or an innate biological vulnerability of those groups, but instead that it is racism, not race, that is a risk factor for dying of COVID-19. So we can think about these communities being more exposed on the front line in terms of jobs, um, uh, the vulnerabilities of communities, and even some of the diseases that we see in higher rates in Black and Brown communities, like diabetes and obesity, that seem at this point to increase the risks of negative impacts of COVID-19, negative outcomes. Even those, there's a lot of research showing that those diseases themselves are kind of social biological conditions in those communities that have to do with various social determinants of health. So I'm going to, talk about health data and how we can connect those to health equity. And one of the things about COVID-19, right, is that we're seeing this health these health disparities in COVID-19, but they really are tragically just shedding light on older patterns of health disparities in the US that we've seen already. So I'm going to be talking about sort of health disparities more broadly, and how we can think about health data and various health technologies being able to address these longstanding, stubborn patterns of health disparities that we see. Next slide, please. So and the kind of health data that I'm going to talk about is what has been addressed or talked about as big health data. So, what about big health data? So, if health disparity issues are not new, and we've had health data for some time, how can there be anything new? Well, there are these new big health data. Are these new health technologies. Can these kinds of relatively new forms of data be used to help to address health disparities in new ways? So these are some of the questions that I want you to keep in mind. Next slide. And so, what do I mean by big health data? What do I mean by these relatively new forms of health data? So, for me, these are the kinds of health data that I have in mind. Genomics, which are still relatively new, right? We've expanded the field from genetics to genomics over 10 years ago now, but it's still a relatively and sort of developing form of health data. Electronic medical records data, which in the US, President Obama passed the High-Tech Act in 2009, and there was this rapid switch from um, physicians and other medical offices sort of having paper records to rapidly digitizing and having electronic medical records. So there's this again relatively new form of digital data. Digital health data that we didn't have before. Internet of Medical Things devices, which I think of as web enabled medical devices like web enabled glucose monitors and things like that. And then various other mobile and digital technologies that themselves sort of produce health data. And some of these we can think of as social media. Social media platforms produce health data in terms of people writing about their health data. And we can even make some observations about people's health based on how they use social media. Activity tracker data, of course, also is a source of health data, as well as multiple other apps that are health apps and just other kinds of apps that we can extrapolate health information from. Next slide, please. So keeping these relatively new forms of big health data in mind, and I should also say all of those forms of data that I had listed on the previous slide, these are large quantities of health data as well, right? They're big data in the sense that in the way that big data has been defined in terms of volume, large velocity, and that these data are coming are being produced rapidly and changing rapidly as well, right? And also very varied. They're different forms of data. So when we think about this big health data, there's obviously not a shortage of this kind of data, but I think the more powerful question is how do we harness the power of this data to not just gain new insights about health and disease or about individuals or about groups, but can we actually harness the power of this health data to advance health equity? Next slide, please. So this is one of the questions that I had in mind some years ago when I and a colleague of mine, Michaela Pitcan, conducted the Fairness in Precision Medicine research study in February of 2018. And we really, at that time, were seeing that big data in multiple other fields, criminal justice, in insurance, other kinds of fields. We saw big data was being used. Companies were really snatching up this data, using it in multiple ways, but there was already evidence that the use of big data was leading to exacerbating already existing patterns of discrimination or creating new forms of exclusion and discrimination for particular groups. So at the time that we did this study, we saw this happening in other fields, and there was not yet really an investigation of how big health data could potentially, what the pitfalls of using big health data would be in the healthcare space. So this was the kind of question that we asked that motivated this kind of study. And we asked a number of researchers, patients, others involved in using big health data, software designers, and really asked them this question. We understand that there are promises for using big health data, but what are some of the pitfalls? What are some of the ways that we could see this data having bias or potentially having negative impacts, not just on individuals, but on already marginalized groups as well? Next slide, please. And you can find the entirety of our report. We have a smaller primer on precision medicine, and we have that full report available for anyone to download on the Data and Society website. And I just will summarize some of the points that we made, some of the findings from that report. We essentially used from our research, we were able to sort of outline some elements, some dimensions of algorithmic bias in precision medicine. And we identified a number of dimensions and a number of places where issues where we could see algorithmic bias, the potential for algorithmic bias in precision medicine. And one dimension is sort of thinking about who is missing or underrepresented in the data. So a number of our informants sort of talked about that on the one hand, though these new forms of big health data, like electronic medical records, for example, there is so much data there, and it is such a rich source of data in some ways, but in other ways, it's actually quite fragmented, and people are not represented in health records in equitable or sort of in the same way. And so that's something to keep an eye out, is to think about who's missing and underrepresented in the data. Another point that is important for keeping in mind for sort of thinking about algorithmic bias and precision medicine is how groups are represented in the data. And issues of data bias are becoming more commonplace now. A lot more, people sort of understand that, yes, if people are missing from the data, that's going to be bias, and anything you do with it, it's going to be problematic. But what we also found is that it's not just an issue of who is missing. Groups might be present in the data, and they might be present in a representative kind of way, but it really also matters how they are represented. And I'll get into that a little bit more in the next couple of slides. But that's another question that another issue that we came to, that it's not just about being missing or fragmented, that's important as well. But even when sort of groups of interest are there, you have to take a really close look at actually how they're represented in the data. Another issue that we discussed is how the data is cleaned and analyzed and by whom. And so again, many people, there's a sort of a rising awareness that, of course, data, even though it appears to be objective, is never raw, is always cooked, is always manipulative, is always manipulated, I should say, and is always representing a particular point of view, which may not be bad or good. That's just the way it is. And when these data are cleaned and corrected and we heard this from the software engineers and others that we worked with, that these processes of cleaning data to have them be used in models and things like that, there are a lot of decisions that are made along the way that are part of this process of cleaning the data that are actually value judgments about what the data mean, what these variables actually say, how we can put them together. And so it's really important to see how that process of data cleaning is actually happening and who is doing it, because the groups or people who are doing that data, if doing that data cleaning, if they have all of the a similar view on the world and have similar values and similar assessments of what data means, then they are going to clean the data and make judgments about the data in a particular way. Two other points: which labels are used in models. This also relates to kind of a data analysis process. And then this last point, the disproportionate impacts of models. This again kind of gets away from not just focusing on the issue of data bias, and we have to get rid of biased data, but this last point sort of emphasizes the idea that even if in some ideal world you have perfectly unbiased data, or if data is always biased, but at least we know about it and it's transparent, that we're not still out of the woods. We still have to think about how these models are used, how they're deployed in the world, and if, as these models are used, they will have different impacts on groups. So again, even if we can think about these models some ways as being completely accurate, we still have to see how they're being used in the world. Next slide. And then expanding from this work with the Fairness and Precision Medicine Project, and sort of thinking about how big health data raises these issues of algorithmic bias along some of the similar dimensions that we've seen these issues being raised in other fields, we really began to connect the pitfalls of big health data, not just to bias and fairness, but really health equity, and how using AI can actually exacerbate health disparities, right? Not that just that it's a pitfall, but that it's a real danger to consider. So this is a an op-ed that I wrote with a physician in a few months after we released the report to really start to get this idea of wait, AI and medicine might not be the savior that we think it is, and we really have to sort of raise this issue. Next slide, please. And since we did that work in 2018, fortunately or unfortunately, we've seen a lot more work in this space where people have been looking at algorithms, AI, and bias with big health data, and have really highlighted some of the dimensions that we found in our work about how how we can see bias being produced by some of these models. And I just want to share a few examples along the dimension of how this issue of how groups are represented in data, because like I said, I think most people understand that if you have a missing data set or if groups are missing your data and your subsequent models are going to be problematic, but the way that groups are represented in the data can be problematic. And I also want to give an example of this last example of, the model could be working correctly, but could still have negative impacts. Next slide, please. So one example that illustrates this first issue of, it's not just groups being missing from the data, but how they're represented in the data is an article that came out the following year after our report that looked at electronic health record data and looked at clinicians' notes. So in an electronic medical record, there's multiple different fields, and there's also fields where physicians can, write notes about patients and write their observations, similar to the way physicians have always written notes, handwritten notes, but these are just clinical notes. And this article examined the ways that physicians wrote about different patients, particularly around mental health in their notes, and it found some really interesting differences between groups. Next slide, please. So again, this isn't an issue of missing data or data bias in the sense of missing data, but what they did find was how these groups were talked about differently and sort of represented differently in clinical notes around mental health. And what they found in particular is when looking at clinicians' notes around mental health, they found that white patients had higher topic enrichment values for anxiety, chronic pain, while Black, Hispanic, and Asian patients had higher topic enrichments for the psychosis topic. So again, just in terms of mental health, we saw these researchers found a pattern where essentially white patients' mental health was sort of talked about in different ways than persons of color. And when these clinical notes were then used for to develop models, they found that these models sort of work differently because of the way that patients were represented in that data. Next slide, please. And this is an article that has become quite well known in the Healthtech space and in this sort of emerging subfield of looking at health and AI. And this was an article that came out late last year that was an example of this this dimension of algorithmic bias of the disproportionate impacts of models. So here, this wasn't an example of data being missing or groups being missing, but this was, or the model sort of working incorrectly. In this case, the model actually worked correctly. The problem was the output that was selected. So essentially, what this model did, it was a model that was trying to determine how to direct resources to healthcare resources to patients in a hospital. And what the model ended up doing was favoring less sick white patients over sicker Black patients. And the reason why this model did this is because it was using healthcare expenditure as a proxy for illness. So the logic was, if we see who is, getting the most money spent on, these have to be the sicker people, right? Because sick people cost more money. You spend more money. The sicker you are, the more money that's spent on you. But that's not the case in the United States, unfortunately, right? Because of our histories of racial discrimination, that actually sicker Black patients overall, less sick white patients, there's actually more money spent on them. So this model that was supposed to be directing resources to people who needed them the most was actually, again, continuing this pattern of marginalization. And again, if you sort of looked technically at the model and how it was working, there was nothing technically wrong with the model, but it still had this disproportionate impact. It was this question of what was the output that was used. Next slide, please. And then one other one other feature that I want to just highlight, and this is from an article that was published earlier this year called "Hidden in Plain Sight: Reconsidering the Use of Race Correction in Clinical Algorithms." This is again one of these places where, if you don't know the history of these data and it's not quite obvious, right? It's not that there's a whole, you can see that there's you have a missing cell of a certain group, or even the previous example where you can run the model and see that different groups are talked about differently. Here, this is an even more sort of embedded bias that impacts health data, where there are race corrections that are used in various clinical algorithms. And these algorithms have been used in medicine for decades, right? But what happens is these clinical algorithms, there's sort of a weight attached to various clinical conditions. And these what this does is that for example, one of the clinical algorithms that's used is one that when people get tested for kidney function, there's an algorithm. If you are Black, it sort of automatically adjusts your score. And there's an African American kidney function score. Now, that clinical data, right, with that adjustment already in there, could be used by model developers. And if there isn't if it isn't known that those data themselves are already corrected and are already corrected by race, you can see the sort of cascading, but yet very hidden ways that there could be bias in that kind of process. And this article, I should just say again, came out in 2020, and these algorithms, these clinical adjustments, these racial corrections have been used for years, and many of them have been questioned, but they're just sort of tradition and they're entrenched in clinical practice and have been used. I remember when I was doing my field work in a hospital a number of years ago, there was a fellow a nephrology fellow who was a Latina woman, and when it got to the point where she was talking about how her the attendings sort of use this kidney function test, they said, oh, well, and she actually said, well, there's a correction for Black patients, and you don't use one for white patients. What do you do with your Latino patients? And she went around and asked different clinicians, and she got different answers for every clinician. And this was in 2012. So these kinds of corrections are just part of clinical practice that have just been used and have been questioned, but haven't been questioned at the in the way that they have been just recently. So actually, very recently, one of the major hospital systems in the U.S., Brigham Women's, decided that they are going to stop using the kidney function racial correction score in their algorithms. But there are still many, many more. This is just an excerpt of one page of a longer table of clinical algorithms that are used. And I have an excerpt from a tweet from a researcher here who is essentially asking that there are these algorithms that are used clinically, and then there is that clinical data that's used by app developers, let's say, who create things like breast cancer risk calculators, app-based breast cancer risk calculators. So how do they, is the racial correction that's already built in used in those calculators? Are these app makers going to address this? They may not even know that these sort of corrections are already built into the data that they are using to build their apps, to build their calculators. And I'm just going to conclude. I have two more slides. Next slide, please. So I just want to wrap up with some more recent work that I did. the FDA here in the United States, the Food and Drug Administration, is the agency here that's charged with sort of ensuring the safety of medical devices. And as AI and machine learning has become more used in health, more used with health data, there's been increasing attention to the FDA needing to actually regulate software as it would other kinds of medical devices. So the FDA has recently put out some guidelines, some draft policy guidance for how to evaluate whether or not, just as they would evaluate whether or not medical devices are safe, how they would evaluate whether or not AI in health is safe for consumers, safe for the public. And what was quite shocking for me as I read this draft guidance is that there was absolutely no mention of group harms when talking about the safety of these of the use of AI in medical devices. So there was no attention to how, again, not just how these models could be used and whether the data would be accurate and whether the processes of data analysis and cleaning would be accurate, but how there could be issues of data bias, algorithmic bias, and again, how these models, once used, once deployed in medicine, could have disproportionate impacts on different communities. So what I did was I sort of envisioned a pathway that was informed by centering health equity, by putting health disparities in the forefront of this policy guidance. Next slide, please. And you'll see an image of the overlay of the FDA's original policy guidance for what good machine learning practices would look like, and my suggestions in the red circled areas here of if we were cognizant, right, that these data can have impacts on marginalized communities, can already exacerbate existing patterns of marginalization in health, can exacerbate existing patterns of health disparities, what would we need to do to really make a more comprehensive set of good machine learning practices? And so I started with in the beginning, before in the sort of pre-market review process, there would be a data bias review, sort of going through the kinds of data bias that I mentioned earlier. There would be, when the model was actually developed, there would be attention to, again, some of those decisions that are made about how the model itself operates. So there's different ways to optimize models. You can look at equal performance. Those decisions, depending on how you make those decisions about how to optimize model performance, have different impacts for different groups. So there would be a very clear and transparent process of how decisions would be made for models, keeping in mind that those decisions could have different impacts on different groups. One of the things that the FDA does is it sort of gives a certification to organizations that have committed, who have demonstrated a culture of quality and excellence in their technical work. And I would add that having a knowledge of the health disparities in their in the domain of interest, in the domain that they're developing technologies about, would be another way to demonstrate a culture of quality and organizational excellence. And if we go back to the Obermeyer article, where the algorithm for health resources, didn't make the connection that the healthcare expenditure wouldn't correlate or have this connection with a racial disparity. If there had been a knowledge of health disparities in that field of, we already know when we're talking about health expenditures that there's a difference by racial group, we may not have gotten to the point where that model would have been developed and would have discriminated against different racial groups. And then lastly, this last point here in real world performance monitoring, if there is an emphasis on health disparities, there would be a health equity review that would continue to see, as this model is being used, after we've done all these checks in the development of it, is it actually addressing health disparities? Is it making it worse? What kind of impacts is this model having on the real world? And this is my, I'll just jump through my two final slides. I know I'm over time.
It's lunchtime.
Yes. I'm going to just zip through these next two slides. My last article I encourage you to read is sort of expanding on this idea of how we can think about developing machine learning that would be socially just, that would have social justice in mind. Next slide. And in that article, we spell out a pipeline for how, at each stage of model development, if we were to keep social justice in mind, if we were to keep health equity in mind, these are the different steps that we would need to take. And that's it. Thank you so much. And I have just my final thank you slide. You can reach out to me and look forward to the questions later. Thank you.
Bye.